Welcome to the Progress Profile, Alzheimer's Research in Focus, a four-part podcast series that explores the most pressing topics related to Alzheimer's disease. My name is Lindsay Simas. I'm a licensed clinical psychologist and the Director of Business Development for Pearson Clinical Assessment's Pharmaceutical Division. I'm excited to introduce this podcast to our listeners. In recent years, research and treatment advances have offered hope for more effective Alzheimer's diagnosis and therapeutic interventions. Scientific breakthroughs, clinical research, and drug developments are crucial because by 2060, more than 14 million adults are expected to be living with Alzheimer's disease. In today's episode, Signals of Hope, Science, Progress, and What's Next, we explore current Alzheimer's research. What shows promise, what still needs to be understood, and the role that research can play in delivering tools to diagnose and treat patients. Our conversation will be expertly guided by our moderator, Dr. John Harrison. Dr. Harrison is an acclaimed cognition expert whose main professional interest is in helping people understand, maintain, and enhance their cognitive skills. In the past 25 years, Dr. Harrison has assisted more than 80 CNS drug development organizations with the selection and successful integration of cognitive testing into therapeutic development programs. Today, Dr. Harrison is speaking with Dr. Jeffrey Cummings, a world-renowned neurodegenerative disease expert who ranks among top scientists in the world. He has authored or edited 43 books and published over 900 peer-reviewed papers, transforming our understanding of neuroscience. Both Dr. Harrison and Dr. Cummings have been involved in the research and development of treatments that will be discussed during this episode. And with that, I'll turn it over to you, Dr. Harrison.
Lindsay, thank you for that wonderful introduction. It's very good to have this opportunity, and I'm delighted to be joined today by Dr. Cummings. Jeff, you and I have worked together for many years and often had the opportunity to discuss the challenges we face in bringing help to people living with Alzheimer's disease. Thank you for being here. I'm very much looking forward to our conversation. And let's start with your annual report, The Circle of Hope, in which you highlight the drugs currently in development for Alzheimer's disease. What do you find most hopeful about the 2025 pipeline?
Thanks, John. Really great to be with you today. And I'm sure we're going to have a great conversation because you have great questions and there's so much going on in the field that it's a pleasure to discuss it. So our pipeline report just came out last week. I'm delighted to have it out in the public. The pipeline this year is so interesting to me because there is momentum in almost every front. So there are more clinical trials in Alzheimer's disease this year than last year. There are more new drugs in the pipeline this year than there was last year. Particularly interesting to me is that phase 1, where of course where drugs begin their journey, phase 1, phase 2, phase 3, eventually to regulatory review and possible approval, that the phase 1 population is almost twice as big this year as last year in terms of the number of new agents that have entered the pipeline. And that, for me, forecasts a robust, continuing growth of therapies for patients.
Yeah, Joe, I agree. I think there's good cause to be positive. And I'm stunned to hear that phase 2 and phase 1 are so buoyant. That's really very good news. And the increase in the number of phase 1 trials is very positive news. And I think more than ever, I think it's important to give these compounds the best possible chance of success. But a concern I know you and I and others have discussed often is that many of the clinical assessments we employ don't really seem to be fit for purpose any longer. And they often date from the 1970s, the 1980s, when we had a much less thorough understanding of early disease presentation. And you'll know that a challenge we've encountered is that many of the cognitive and functional difficulties we hear about from people living with Alzheimer's disease are not well, and frankly, sometimes not at all indexed by these trial measures. We still seem to be very focused on memory, and other important cognitive abilities are often overlooked. Jeff, are you seeing protocols focusing on cognitive abilities beyond memory? And if not, what can we do to move the dial on this issue?
John, I'm a little hesitant to discuss this in your presence because you're one of the great champions of the need for change in terms of outcome measures, cognitive and functional in particular. But I'll give you my opinion. I'm anxious to hear your opinion as we discuss this today. John, it's amazing how our tools that we're using in contemporary clinical trials really are quite old. We define patients with the mini mental state examination. That was published in 1975. We measure their cognition by the ADAS-Cog. That was published in 1984. And we measure their functional abilities through the ADCS-ADL scale, and that was published in 1997. So these are tools that reflect a time in history where lives were quite different than they are today, and yet we're still measuring them measuring the outcomes of trials using these older tools. I think we can do much better, and we are stuck both for cognitive tools and for functional tools because the pharmaceutical industry is very conservative. They want to make sure that they are presenting to regulatory agents results from tools that are widely known and whose psychometric properties are very well established. And that takes us back into yesteryear. And I think, John, you've been one of the pioneers in terms of the NTB, the neuropsychological test battery, and getting people to think about that series of tests rather than the ADAS-Cog as an alternative for clinical trials. And then the work on the Amsterdam ADL, I think, has been terrific in terms of a better ADL tool. But again, we're not seeing it used that widely in clinical trials yet. So I think tools are out there. I think they're emerging from the academic community, but they're not being integrated in trials yet. And I think we have to have a bridging strategy, John, where both tools would be used in a certain number of trials until you began to understand the relationship between the two tools, and then you would drop out the one that is least effective. So I think there is a path forward. It's long. It has to be very strategic, but the tools are there. But I'd be interested in hearing your thoughts about this. You're the one who spends all your days thinking about this.
Ranting from the sidelines often, aren't I? Yeah, I think there's plenty of opportunity here, and your points are very well made. So much of modern life is not captured by the instruments we use. I'm 63 now, but when the ADCS ADL came out, there were fewer opportunities to interact by email, over the internet. I used to have to get printed tickets when I went to the rail station. Now I have electronic ones on my app. And these things are just overlooked. And commonly now in Amsterdam at the Alzheimer's Center, we diagnose working people in their late 40s with Alzheimer's disease. And they're clearly people that are high functioning and engaging with the world in all the ways that you very helpfully outlined. So I think we could, should, and must do better. And there is, I think, a sort of groundswell of opinion. There's an opportunity there. I'm happy to say, as you rightly point out, the agency tends to take the things that we send them. But the agency back in 2018 and just last year reiterated that they have an appetite for what they describe as sensitive neuropsychological measures. We haven't really taken that seriously. That surprises me. Most sponsors seem to live or die by agency guidance. And when we get very clear guidance, I think in the 2018 guidance, the ADAS-Cog and CDR sum of boxes weren't mentioned, but sensitive neuropsychological measures were listed 17 times in a relatively short document. So it seems to me the agency is hungry for something else. And clinically, we've got really good experience of other measures. So I completely accept your premise that there's a comfort to be had from using tools that have some provenance in this area. And we've been using the LMSC, the ADAS-Cog, and others for a good number of decades. But in that time, we've learned a good deal about early Alzheimer's disease and presented case studies at conferences about high-functioning individuals who come to us because it's their problem-solving, concentration, or executive skills that have been compromised. Memory's taking a hit, but it isn't really the thing they complain about. And yet the ADAS-Cog is really, in a mild patient, just a test of episodic memory. So if I think of some examples, there's traditional paper and pencil measures. You were kind enough to mention the neuropsychological test battery, which was highly experimental. I mean, it really was almost like a tertiary outcome measure. And in a very abbreviated study with a relatively small cohort, we saw some signal, which was good in the sense that it opened the door to new approaches. But if anything, it was a little bit too successful. So rather than sort of hone the content, we then went forward with the whole NTB, which I think most of us felt was probably a little cumbersome. But if I think about, the catalog of tests, we've got the repeatable batteries like the R bands. There's the Dennis Kaplan executive function system. And we've got equally positive experience of using digital cognitive assessments. So, people like Cogstate, Cambridge Cognition with the CANTAB system, cognitive drug research system now in the hands of Signant. These have been around for the most part 30 years. And I always have to laugh a little when I hear new digital biomarkers. These are things I've got literally half a life of experience of. They're coming to a fore, and that's to be welcomed. But I do think that failing to assess executive function, working memory, and attention, even to be honest, language and praxis, people tend to perform at ceiling on our ADAS-Cog tests of praxis and language. But even a very little time spent with these same individuals can reveal clear deficits in their language skills. So I think if we don't fix this, it's an opportunity missed. And at the very least, it seems to me the drugs we have and may actually be better than we think. It's just that we've never taken the opportunity to evaluate these equally important aspects of cognition. Memory always front and center, but it's very important, I think, to be mindful that there are opportunities in these other areas. So, and if the agency are telling us let's do neuropsychological measures, then I think we should take that as gospel. There's an adage in Lewis Carroll's work where he says, anything I tell you 3 times is true. So maybe the agency has to tell us one more time and we'll say they really mean it now. So that's my hope.
But one point I'd like to make, John, is
Sure.
You're talking about new tools. One place where we're seeing new tools are in new populations. So as we're moving further and further into mild populations, patients are either asymptomatic but biomarker positive, or minimally symptomatic. There, where we have confidence that the ADAS-Cog is not sufficiently sensitive, we are seeing new tools come in. The tools that are being used in the prevention trials, the tools that are being used in A345 or in the API trials. Those are new tools, and I think that might also be the stepping stone to discussions with the agency about new tools. So I do see some progress in that regard. And one historical note, John, the reason there's an ADAS-Cog is because there was an ADAS non-Cog. And very few people remember the ADAS non-Cog, but it measured many behavioral features and was soon replaced by the neuropsychiatric inventory when we published the neuropsychiatric inventory because it was a better tool. So the ADAS non-Cog has almost disappeared from historical memory now.
Yeah, when I train people on the ADAS-Cog, I always mention it, and there are a lot of perplexed faces in the room that it ever existed. So it's sort of the mad ants in the attic of the ADAS-Cog is the way I always think of this. I think that there are glorious opportunities, and I, to your point about new tools, if I'm talking to sponsors about using a digital test like a reaction time test, which is a very efficient way of capturing attention, there's always concern about this being a new test. And when I announced that it was used in the Netherlands in 1868 for the first time, admittedly not with a computer, there's some sorts of relief that actually it's probably not so new. So I think, I hope there's a lot of psychologists listening to our call today. And I do encourage all of us, brother and sister psychologists, to get engaged with this process. It's still quite unusual for there to be any other psychologists than me in the room at these events. And it would be nice to fix that. So there's a little call to arms for my fellow psychologists. If they have the inclination, come and join us and join the fight to get better outcome measures.
I would say that it's important to keep in mind that these tools have different roles in different phases of drug development. So something like reaction time, that can help you with a no decision in a phase 2 compound where you're trying to understand, is there a cognitive signal? And pair that with a biomarker, for example, to help you understand that. Whereas I think the regulatory agencies are in general skeptical about the relationship between computerized measures and real effects on patients until they have rigorously demonstrated. Uh, but it just means that choosing the right tool for the right stage of the development program is the key to the success of being able to advance drugs better.
Yeah, no, thank you, Jeff. I do need to move on, but I can't resist but to pitch in and just say we actually have very good experience when we are innovative in the way you describe. So I think if I were talking to a sponsor, and this has actually happened in the past, where we've designed the study we'd like to do, and then we've written another synopsis of the one we think we'll end up doing, which is the kind of things that you typically see. And in one case, we made a plea that if the ADAS-Cog was selected as the primary outcome measure for cognition, could we at least restrict the study to moderate stage patients on the basis that the sweet spot for the ADAS-Cog is really people with a mini-mental state score in the mid-teens. And the phase 2A study read out positively, which we thought was fantastic news. But when it came to do the replication, and it wasn't really a replication because we then went to mild to moderate, and sadly the drug didn't prevail. So I think there is little hints in the literature. I mentioned digit symbol substitution. Galantamine was investigated back in 2008, at least reported in 2008, in a mild cognitive impairment study where, probably unsurprisingly, the ADAS-Cog didn't show anything. We should move on, Jeff, shouldn't we? I could talk about this all day, but I probably shouldn't. So let's go on. Let's move to consider other possible treatments. And Jeff, one drug scheduled to be up for approval in 2025 is semaglutide, an oral drug already approved for treating diabetes and obesity. What are your thoughts on this compound as a potential medication for Alzheimer's disease? And what impact would the approval of an oral medication have on the field, please?
Thank you, John, for asking this question. I think this will be probably the most interesting readout of 2025. As you know, the currently approved new medications, which we are delighted to have, are complicated to use. They're given intravenously. They have to be monitored for side effects. They produce cognitive slowing, which we're delighted with, but not enough. So we would like new and better drugs, or maybe new and better drug combinations using new drugs with existing drugs. So semaglutide is in that firmament of compounds where we're going to have new data this year. It's going to be so exciting. It'll read out at the end of the year. And as you say, this is a medication which is prevailed and approved in diabetes and obesity. And the interesting thing to me is that in those trials, when they have looked at cardiovascular events, when they have looked at renal disease, those patients have also improved in terms of those parameters that are probably measures of the vascular impact of the diabetes or the obesity. So the semaglutide is an anti-diabetic agent, a GLP-1 agonist, and as such, it has lowered abnormal insulin levels to normal levels, but it does not lower them further so that the risk of hypoglycemia is low. And it has anti-inflammatory effects. And the hypothesis for semaglutide in Alzheimer's disease is that inflammation is a very important part of the disease. We see it on every autopsy. We see lots of peripheral evidence of inflammation in Alzheimer's disease. And the hypothesis is that semaglutide lowers peripheral inflammation, and that will lower central inflammation. And the result will be an improvement in Alzheimer's disease, or a greater slowing in cognitive decline than is seen without treatment. Semaglutide does not cross the blood-brain barrier under usual circumstances. It's a large molecule. In Alzheimer's disease, the blood-brain barrier is adversely impacted by the inflammation. So it may be that all these things are working together, and that the blood-brain barrier can be reconstituted. The inflammation will go down. The inflammation in the brain, the activation of the cytokines that have been so destructive in the brain will be reduced. So this is the hypothesis, and I would say that the drug has lots of non-clinical support. It has lots of epidemiologic support. You can see a reduction in Alzheimer's disease in diabetic population when you study them. And it did not have a strong phase 2 program where you actually studied it in Alzheimer's disease and showed it had this benefit. So I would say that this is a promising compound, but it has risks if you look back at the development program, and we all have to keep that in mind as we're trying to communicate our enthusiasm to our patients and to our many families that are waiting for new therapies. So I personally am excited about this drug. I think it has a unique mechanism of action and a good track record. And I'm also very aware of vulnerabilities in development programs that can show themselves later in development. So we will see, and I can't wait to see.
Yeah, no, thanks, Steph, and I share your optimism, and I just wanted to visit the theme of it being an oral medication with you. So many of the drugs we have to hand are a little bit of a burden to healthcare providers, caregivers, and patients. Is the fact it's an oral medication a really big plus to the field?
I think it's a really big plus, John. The idea that we could get to patients who cannot get to infusion centers or cannot readily learn how to do subcutaneous injections. I think that makes just literally a world of difference in terms of the accessibility and reach that the drug could have. And when you combine that, and I know you're going to talk about this later, John, but when you combine that with the possibility of using a diagnostic blood test, now you have a blood test for diagnosis and an oral medication. Wouldn't that be a great place to be in 2026? I'm hoping for the best. The blood test, of course, has made tremendous strides, and we'll have the answer on semaglutide by the end of the year.
No, thank you, Jeff. And on that theme of wanting to make sure that we address all the presentational features of Alzheimer's disease, I wanted to ask you about other classes of drugs that are targeting what we think of as psychiatric presentation, like agitation and psychosis in Alzheimer's disease. How important do you think it is that we're developing treatments for these behavioral symptoms?
I think this is tremendously important, John. Mm-hmm. Thanks for asking. Mm-hmm. We talk about the long gap in the development of new therapies for Alzheimer's disease for cognition, which was 2004 to 2021, between the approval of memantine and then the approval of aducanumab. So almost 20 years elapsed in terms of approval of a new treatment for the cognitive aspects. But we tend to forget that there was no treatment or the behavioral aspects of Alzheimer's disease until 2023, when brexpiprazole was approved for agitation in Alzheimer's disease. And that was the very first drug approved for any neuropsychiatric indication in Alzheimer's disease, and only the second for any neuropsychiatric indication in any neurodegenerative disorder, the other being pimavanserin for psychosis and Parkinson's disease. So this is really important progress, and you see that progress breeds more interest in an area. So right now, there are several more drugs for agitation in the pipeline. There's some very interesting work on psychosis in Alzheimer's disease in the pipeline, and there's interest in apathy as a treatment target for Alzheimer's disease. So we're seeing a real increase in the interest in treating neuropsychiatric symptoms in Alzheimer's disease, and we're seeing success. So it's just, I think it's a great part of the story that's going on now.
No, Jeff, thank you. And I share your sentiment. When I sit in with clinicians, we're very focused traditionally on drugs for the very front end of Alzheimer's disease. So when we think that we can maybe arrest the progress, but clinicians I've worked with have universally said, well, I still have to care for people in this moderate and severe stages, and I really don't have much to go to when it comes to managing a lot of the signs and symptoms we see. I just want to expand that issue a little bit with you. So, one of the things that we tend to notice is that people that have presentational symptoms and signs like apathy, maybe agitation, in other contexts, pain, presumably the fact that they're having to deal with pain, they're not feeling as enthusiastic as they used to, and maybe even depressed, to take another obvious example of an area where we know patients can present with depression and Alzheimer's disease. It seems reasonable that if you're depressed, agitated, and anxious, your cognition might not be quite as good as you'd like it to be. So, do you think there's opportunities there? If we can start to manage these psychiatric presentations more successfully, might we see cognition sort of float up as we ameliorate their condition?
Yeah, I think that's a really interesting idea. I haven't thought much about that, John, but of course we do see the sort of the counterpoint of that, which is when you improve cognition and then measure behavior as a secondary outcome, you do see improvement in behavior. So you give a cholinesterase inhibitor and you reduce apathy and hallucinations. You give memantine, you tend to reduce irritability and agitation. I can readily imagine the reverse occurring, that the optimization of circuit function that leads to a reduction in neuropsychiatric symptoms would also have a counterpoint in terms of improving cognition. And that would be great. I haven't thought about that. What a great idea. I think we need to be on the watch for that. And that means we're coming back to the tool idea here, having the right tool in those trials to make sure that we could catch what might be a relatively subtle cognitive benefit.
Mm. No, thank you. Thanks, Jeff. And so if I hop across the fence to psychiatry, which I've often done in my career, if I think about the development of antidepressants, which also seem to benefit cognition. So vortioxetine from Lundbeck, for example, I think was a really nice success story. It had antidepressant properties, but it also seemed to have an independent cognitive improvement too. And as I'm sure you'll know, people with depression, even if they're between episodes of depression, are often still afunctional and sometimes just dysfunctional. And that might be because the cognition's not lifted at the same time as the mood. So if I think about the opportunities in treatment of Alzheimer's disease, but potentially other dementias too, if we can address all these areas, we might find that there's an additive, maybe even a synergistic effect. And vortioxetine is, I think, a good example to think about. In major depressive disorder, we were sort of coming to evaluating cognition for not quite the first time, but quite early in the development of that class of drugs that vortioxetine represents. And we didn't have the legacy we have in Alzheimer's disease of traditional measures. So we literally just said, what would make a good cognitive assessment? It had good content validity. We measured attention with digital measures. We measured working memory with digital measures. We used paper and pencil measures for episodic memory and various other aspects of cognition. And happily, we were rewarded with a positive treatment effect, which was independent of the mood alleviation. So when we're allowed to be, sort of first principles test selectors in other indications, it tends to go rather well for us. And you very helpfully mentioned other forms of dementia. In dementia with Lewy bodies, in the last 2 or 3 years, we've had some very positive signals on other measures than the ADAS-Cog and the traditional text that we would use. Sometimes digital measures like the CDR system, the COG state system at EIP Pharma. So it just seems to be easier in these other indications to use the kinds of tests that we think might do true justice to our compounds. Is that a sense you have of this opportunity too?
It is, John. I see, for example, a recent study on apathy in frontotemporal dementia that was positive. Really interesting study, and that was an example where apathy was the primary outcome. And so you're looking at a different set of outcomes, chosen appropriately for the goal of the trial. So I was very encouraged by that. And dementia with Lewy bodies is another area where we're seeing a lot of activity. I think the regulatory agencies are now recognizing DLB as something that clinicians can diagnose and patients that desperately need therapy.
Yeah, no, great. Thank you, Jeff. And I think worth saying also, computerized assessments do bring other advantages. And I think we learned this during the very unfortunate COVID pandemic, where suddenly we were really tested to keep trials on track. And remote testing, often facilitated by computerized assessment, proved to be a bit of a savior in more than one trial. And we were sort of held to it, and necessity was very much the mother of invention for us. It's just worth reminding people, scaling up with digital testing is just that much easier. And it can just be rather more convenient. We often ask sites to do quite challenging paper and pencil tests. And, with the best will in the world, sometimes the raters aren't available. Computerized testing just smooths that process. So it's always worth reminding people that that opportunity exists. Not least for disease detection. So, Jeff, something we've wrestled with in our field is the proportion of people that screen fail in the studies we conduct. I've seen numbers of 75%, sometimes even pushing 90%. And the idea that we might start to pick people up remotely by offering them the chance of remote assessment, just to kind of get them in the funnel, seems very tempting. And with so much interest in digital testing, smartphone monitoring, speech analysis is an area I think has particular promise. I think it's just about using the best tools to detect and then track disease. The promise that we've had so far, I'm looking forward to more revelations this year. And I think speech is nice because it's one of those things we don't have to ask people to do something else. So much of the cognitive field is saying, well, I'd really like to spend half a day testing your cognition, which rarely goes down well with anybody, least of all sponsors and the clinical operations thing. So the idea that we might be very efficient at doing this and doing it remotely does seem to me an opportunity we should grasp. But Jeff, what are your thoughts and what's your experience?
Yeah, well, I think the digital divide is about to occur here, where we're entering a new land of digital applications. There has been a lot of growth in digital technology, and not very much use in clinical trials yet. But we're following this very closely now in our observatories, where we watch what's going on in clinical trials. And we do see some use of digital biomarkers, I'll call them, and digitized tests of other types. So I think it's coming. I think it certainly lends itself to remote testing, and we want to make patient trials more patient friendly. We want to be able to offer patients something where they may be able to benefit, can certainly contribute to the growth of knowledge and the growth of new drugs that might be beneficial to them or their family members. And we want to make it convenient for them. And I think so very often we have constructed tests, as you say, that last half a day, are not very convenient, require on-site administration, and are not really what we're looking for when we talk about patient-centered drug development. They're about understanding the brain better, and that has a great place in terms of neuroscience, but it may not be the best way to approach drug development. So I think we're going to see more digital tools coming in. As you say, they're often more precise. They're often more reproducible. There's not so much site-to-site variability when it's a test that is presented electronically and the response is electronically captured. So there are many advantages to digitized tests, and I think we'll see them. But it is interesting to me that we haven't seen as much as I think we could have seen by now.
Right. Yeah. Yeah. No, I share that sentiment, and I'm delighted that I think the sort of holy grail when I talk to the cognitive biomarker people, the digital biomarker people, is very much, is there a sort of metric that we've maybe even overlooked, or maybe a combination of measures that, when they're combined sensibly, just give us that extra information we've been missing? And I think I recently had a chance to chat to colleagues in Amsterdam after a PhD student viva, and we were sat around the principal ambition of the research that was conducted. It was to look at people who were biomarker positive, various biomarker positive profiles, track them over a year and a half, and look to see what changed in their cognition. And what was really disappointing is very little, which I think was not what we expected. And we had the quandary that people were coming to us because they knew that their cognition was not as good as it used to be. We were measuring their cognition and essentially saying it seems fine to us. And then they come back again and they were continuing to tell them everything's fine, even though they're biomarker positive and telling us that's not their experience of their own thinking. So I think the challenge comes for us is to just do a little better. And I wonder if we maybe have to work people's cognition a little bit harder to elicit the deficits. Maybe, just reading Apple penny table on the MMSE isn't a good test of episodic memory. Maybe you've got to push it to 12 words to really start to see where's the point where the system starts to break down. So I share your enthusiasm, and I think there's a lot of good prospects in what we're seeing come through in this area.
And
Jeff,
I think there is an opportunity for more online testing where people who are concerned, the population you just described, I'm concerned about my memory. What can I do? Well, one channel for those patients should or those individuals are not patients yet. For those individuals should be to be able to direct them to online assessments with a readout that would be informative for them, or would establish a baseline from which they could continue to measure their performance going forward. And we did this with a trial called TrackPad, Trial Ready Cohort for prodromal and preclinical Alzheimer's disease. We enrolled 60,000 people in that study. It wasn't a trial; it was a study. We learned a lot about what tools worked best online. We also learned that people often didn't return, so that the attrition rate in that study was very high. So I think one of the lessons from that is, yes, we can do this. How do we also make it something that patients or individuals worried about their memory want to do again, twice a year or something like that. How do we keep them engaged with this so that they have the information they want at the same time we're learning about how to get patients into trials and develop new drugs?
Yeah, no, thanks, Jeff. And keeping people involved, it seems to me such a critical aspect of what we do. I was until recently Chief Scientific Officer at Scottish Brain Sciences, and they have a very ambitious program with a prospective cohort of people over 50 in Scotland who feel their cognition has changed for the worse. And one of the things that we're learning is, what does it take to engage people? One of the things that rings in my ear on this topic is our good friend Ishta Gavaya, who constantly reminds me about that proverb almost, nothing for us without us. I think there's a lot of people feel that we've done things to them in trials and studies, and actually having them as stakeholders in the process probably gets better data and also makes them more likely to stick with us. Would that be your experience and expectation too?
Absolutely, John. I think this idea of nothing about us without us really resonates with me. I think we want to engage individuals who are concerned about their memory in the design of these studies. We want more and more patient-reported outcomes, which should be about things that they're concerned about. So there are many synergies in terms of the logic of involving people who are suffering from these disorders. The construction of the science that is devoted to them, and into the development of drugs that we think would be helpful to them. In the ACTC, for example, we do have a patient advisory committee, and I think it's been very useful in reflecting on some of the drug development programs that have done by this consortium.
Great. Jeff, thank you so much for that. This is something that I know you feel passionately about, and indeed many of our colleagues do. So it's nice to have the chance to air these possibilities and opportunities. But I think there are other drugs we should probably talk about as well. So I'm going to move us on and take us in a slightly new direction. You'll know anti-amyloid monoclonal antibodies have been approved in the US and other countries for the treatment of early Alzheimer's. But these drugs are administered intravenously and require MRI monitoring for side effects. How are you seeing healthcare systems accommodate to this new?
This has been a real struggle, John, and I think you see it in the United States in the relatively slow uptake of the drugs. see it around the world in the reticence with which the regulatory and funding bodies are considering these drugs. So they absolutely are complex, and the clinician has to take responsibility for them because they have some safety issues associated with them. ARIA, which is the either release of fluid into the brain or the leakage of blood into the brain, can occur with these drugs. It is usually asymptomatic, but it occurs in about, depending on the drug, between 10 and 20% of patients, and between 2 and 5% of the patients have symptoms associated with it. And very rarely they have severe symptoms or death. So this is something that we really have to be on top of the whole time. The vulnerability to ARIA is during the introduction period of the drug. So during the first 6 months is when most of the ARIA occurs. So that's when the monitoring has to occur. So we have lots of management strategies. We've published appropriate use criteria and recommendations for these drugs. But they absolutely impose a burden on healthcare systems and on clinicians and on patients that have not experienced before. So to use them, we have to respond to all of these technological needs, and we would like alternatives, as we mentioned earlier, either to use in combination or instead of the monoclonal antibodies. So they're so important to me because they're the first drugs where we had a disease-targeting drug that showed us the biological impact and showed a corresponding clinical impact, the slowing of disease progression. That is the first time in the history of Alzheimer's disease where we were able to show that our knowledge of the biology of Alzheimer's disease allowed us to intervene in a way that changed that biology. And for me, that is the reason for regarding these as defining a new era. Now let's take the next step, right? Let's go on to the next thing and get better drugs for patients that are easier to take, safer, more efficacious. This is the process of drug development that's so exciting, but we have a solid foundation now to build on.
Jeff, thank you. And just one other theme on that, where you and I have, I think, been in lots of meetings where we've been told in 5 years' time we'll have blood tests for this kind of thing, and then in 5 years they don't show up. They seem to be showing up, Jeff. Are we in that new era now where a blood panel marking various different pathologies might be fairly standard in primary healthcare?
I don't know that we're quite there yet, John, but where are we? We are at the point where a blood test has been approved in the US, and I think will be approved elsewhere, that accurately predicts whether or not that patient, if they were to have an amyloid PET scan, would have a positive scan, or in case of a low level, would have a negative scan. So it has both a positive predictive value, yes, amyloid is in the brain, and negative predictive value, no, amyloid is not in the brain. So those patients who have low levels, they do not have amyloid in the brain, and whatever is causing their cognitive complaints, we need to find out about that. They have frontotemporal dementia or dementia with Lewy bodies or depression, something else that needs our care. And the patients who do have a positive predictive value, then those patients have amyloid in the brain, and they don't need an amyloid PET scan. That was the point of the test. So they could now be considered for treatment for as long as they are symptomatic. I should make that point. These tests are for people who have the symptom complex of Alzheimer's disease. And then if they have a positive blood test, you would say, yes, these patients are candidates for anti-amyloid therapies. There's a lot of other decision making to go on, but it does shortcut that step of knowing who has amyloid in the brain. There's lots more to be learned. There's lots more, blood tests that are being tested. There's many goals to be achieved before we can get this into the hands of the primary care clinician. And I think that's where it will have the major impact on Alzheimer's disease. When you Go to your clinician. You say, I don't think my memory is quite right. And the clinician says, well, we've got a blood test to understand this better. That's where we want to be. But I think at this point, clinicians really, primary care clinicians, have not been following this literature, don't know the scientific advances, don't know that drugs are available for the treatment of this. So I think we have a lot of hurdles to jump before we finally get to the place we want to be in integrating the new biomarkers into the healthcare system.
Okay, no, great. Thanks, Joe. Very, very nice to have that picture of where we're at and where we might go. Thank you for that. And we hinted earlier, we were very focused in that last discussion on monoclonals as anti-amyloid therapy. But there are other promising combinations of medications that might also slow the progression of Alzheimer's disease. I think you're probably pretty well placed to talk about that. Is that something I could get you to opine on, please?
Well, one of the interesting areas or directions that I'm seeing, John, is the interest in tau. We know that there are two major aggregating proteins in the brain of Alzheimer's disease that lead to the death of the nerve cell. One is the amyloid protein that produces the plaque that is reduced by the amyloid drugs. And the other is the tau protein that produces the tangle inside of the cell and kills the cell. And for the first time, we're seeing at least one drug that is having effects on our tau biology measures. This is a drug from Biogen, 080, and 080 is administered by lumbar puncture. So again, you see very complicated methodology. But the drug then produced robust dose-related lowering of tau in the spinal fluid and of phospho-tau, another tau measure in the spinal fluid, and amazingly reduced the abundance of neurofibrillary tangles as visualized by the tau PET scan. So I think this is really a remarkable set of observations. We don't know the clinical impact of that yet. The sample size was very small, so it was informative in terms of the biology measure, the biological measures, the biomarkers, but was not informative in terms of the clinical measures. So, which you were asking about combinations. So let me get back. So one possibility is that we would have treatments for amyloid and tau, the two co-proteins of Alzheimer's disease. And we'd have to figure out how to do that in a way that was acceptable to the patient. But what we're seeing is the emergence of drugs and targets that are going to lead to combinations that make biological sense because we know what the biology of Alzheimer's disease is.
Excellent. Jeff, thank you. That's really helpful. We talked about inflammatory processes a little earlier already, so that goes in the pot too, I guess, right?
Yes, absolutely. Anti-inflammatory drugs. That's one of the most active areas in the pipeline right now, John. So if you look at, what are the areas in the pipeline in terms of targets that are most active, neuroinflammation has about 20 compounds that are being tested. And the interesting thing to me, John, is that nearly every one of those compounds has a different target within the complex amyloid pathway that exists in the brain. And that is going to be so informative to look at this, which ones are powerful, which interventions can change the whole inflammation in the brain and which ones can't. It's just one pathway of many, and therefore ameliorating it doesn't have very much of a clinical benefit. So we're going to learn a lot, and the diversity of targets in the pipeline is, to me, really quite amazing.
Yeah, thanks. So maybe my 5-year window was a little bit optimistic, but if I could get you to prognosticate, maybe in 10 years' time, with the accumulation of the knowledge we hope to gain, is it reasonable to think we might be in a sort of precision medicine opportunity in the treatment of various dementias and different pathologies?
And John, I think you said the magic words there. We are looking for precision medicine, and we're looking. What does that mean? That means for the individual patient, you would have a biomarker, a biomarker profile that says, okay, this patient has amyloid, they have a high level of inflammation, and they have a relatively low level of tau, and we know that occurs. Well, your combination there is dictated by the anti-amyloid drug and the anti-inflammatory drug, and you would deprioritize tau in such a patient, and of course there will just be all these different combinations. Now, getting there from a drug development point of view is pretty complex. Uh, we have we have a target to shoot at, and until you have a well-defined goal for drug development, you can't possibly develop drugs around it.
Right, right. Good. So room for optimism at the very least. And I think just to go back to the sort of cognitivist role in this, I've been stunned across the last 2 decades sitting in rooms with colleagues in healthcare centers who are using neuroimaging or genetic screening or ligands. It's the extraordinary leaps forward we've made with the application of neuroscience in this field has been quite prodigious. And it puts into stark contrast for me the fact that you made the point earlier. Our screening measures for cognition are 50 years old and our primary outcome measures 40 years old. So again, I kind of feel like, we need to be benefiting from all these developments, and hopefully we can take the behavioral assessment and cognitive assessment forward in much the same way as we've done so successfully in these other parts of science.
No, I think that's right. If you think that the first major paper on amyloid PET was either 2004, 2005, and the tremendous influence that amyloid PET has had on our understanding of the disease, defining preclinical Alzheimer's disease, for example, which we just didn't know existed until we could see that the amyloid was in the brain for a long period of time before patients developed symptoms. And now the development of anti-amyloid therapies and the idea of anti-amyloid preventive therapies and the idea that we can change the disease and non-amyloid compounds will be developed. I think so much of this was built on advances in technology that allowed us to understand the disease in the patient.
Mm-hmm, mm-hmm. Jeff, we've time for one more question, and thank you so much for what you shared with us already. I want to make this one a personal one, and I hope you don't mind that. You've dedicated your career to understanding and improving the lives of those affected by cognitive decline, and especially that caused by Alzheimer's disease. What continues to inspire you to do this work?
Thanks for asking, John. There are two things. One is the science is really exciting. I just get up every morning wondering what was discovered the day before. And it's a new blood test or, a new population that we defined or new insight into frontotemporal dementia or some non-Alzheimer's disease. I just find it so exciting. And then, I've taken care of thousands of patients in the course of my career, and I have loved doing that. And I have always wanted to do more for them. I always felt like I fell short of what they needed. And it's true. I always did fall short. I didn't have the tools that we needed to do what was needed to change the brain to allow them to have a dignified older life. And the idea that we are now making progress in that is so exciting to me that I just love this idea and happy that I'm active in Alzheimer's disease research at this time when all these changes are occurring. And I think there's lots of reason for hope. I love this idea of calling our circle where we show all the drugs the circle of hope. That idea itself is inspiring to me, that patients and families find that a circle of hope. And I find it extremely rewarding to be able to make that contribution.
Yeah, I share your sentiment. The science is exciting, but what's really exciting, I think, is the application to try and improve the lives of people who are living with Alzheimer's disease and indeed other dementias and neurological diseases. So I completely understand that feeling. I changed careers about 40 years ago to help people with neurodegenerative disease. And during most of that time, all I really did was monitor their decline. But in the last 2 years, I think there's been so much room for optimism, and I personally have felt a good deal more optimistic about the process. So hopefully we can deliver on so much of the promise that we have in the field. Jeff, sadly, that concludes our conversation. Let me thank you for joining us and sharing your knowledge and expertise. It's been great to hear from you about recent progress in Alzheimer's research, and it makes me very hopeful. Your contribution has been hugely important in gaining a better understanding of Alzheimer's disease and also in arming our listeners with the knowledge needed to advocate for themselves and their loved ones. So thank you again.
My pleasure to be here.
Thank you also to our listeners for joining us. We hope that today's conversation provided valuable insights. Join us for our next episode where Dr. Philip Sheltons and I will explore critical developments in Alzheimer's research and treatment therapies. Until then, thank you for listening to The Progress Profile, Alzheimer's Research in Focus.